Hi, I'm Dr. Gregory Piazza. On behalf of CME Outfitters, I would like to welcome you to this CMEOCast titled Real World Data for Real World Patients, a broadened lens to inform decision-making in venous thromboembolism. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. This activity is supported by educational grants from the Bristol-Myers Squibb and Pfizer Alliance and Janssen Pharmaceuticals, and administered by Janssen Scientific Affairs. Again, I'm Greg Piazza, Director of the Vascular Medicine Section at Brigham and Women's Hospital, and I'm an Associate Professor of Medicine at Harvard Medical School and a faculty of the Cardiovascular Medicine Division. And I'm really pleased actually to be joined by one of my friends and a colleague that I've worked with for now more than 10 years, Dr. Javed Moslehi, who's Associate Professor of Medicine and Director of the Cardio-Oncology Program and co-director of the Vanderbilt Program for Optimizing Immuno-Oncology Therapy, also known as VPoint, in the Division of Cardiovascular Medicine at Vanderbilt University Medical Center in Nashville, Tennessee. Welcome, Javed. It's so great to have you joining me.
Thanks, Greg. It's a real pleasure to be here today to discuss this very important topic. So I look forward to it.
It's great to be united again. What we're going to do, just to sort of frame today's program, is start by reviewing our 3 learning objectives. After participating in this activity, the learners should be able to apply the knowledge of real-world data methodology, study design, and assessment considerations to the interpretation and application of data to everyday clinical practice. That's really going to be learning objective 1. Learning objective 2 is to compare the safety and efficacy of direct oral anticoagulants, or as we call them, DOACs, versus vitamin K antagonists, or VKAs. We might know that as warfarin or other types of vitamin K antagonists. That's learning objective 2. And then learning objective 3 is really to integrate this real world data into practice. There's been a lot of talk about real world data, but how do we pull that into our everyday care of patients, and how do we individualize treatment using this information? That'll comprise our 3rd learning objective. Javed, can you take us through a little bit about what we've learned in the last few years about the burden of VTE in our US population?
Thanks, Greg. Yes, venous thromboembolism really comprises both deep vein thrombosis, DVT, and also pulmonary embolism. It actually affects close to 1 million individuals in the US, 900,000, and leads to about 100,000 deaths that we can account are due to VTEs. It's probably the most preventable cause of death in hospitalized patients, and its incidence has continued to increase as we have a growing and aging population, and as patients live longer with chronic conditions. And as somebody who takes care of cancer patients with cardiovascular issues, it has really become one of the main areas of clinical need, given the fact that over the last decade, we've been so much better at treating cancer, such that cancer now is basically a chronic condition. And in this population, patients can have a high incidence of VTE. And I think that's really important to think about. Now, in terms of what we do for VTE, obviously having a high sense of detecting and diagnosing is key. But once we diagnose, we've learned that anticoagulants are the mainstays of therapy. They reduce the thrombosis, extension, and recurrence and embolization of VTE, and they prevent post-thrombotic syndromes. Now, the problem comes that we have a number of different choices in terms of what the anticoagulants that we can to use, certainly in the cancer population. So we have parenteral drugs, unfractionated heparin, low molecular weight heparin, drugs like fondaparinux, but we also have oral drugs like vitamin K antagonists, drugs like Coumadin and warfarin, and more recently, direct-acting oral anticoagulants, or DOACs. And just to make things a little more complicated, we have a number of different choices of drugs to work with. And there are at least 4 that we generally think of: apixaban, dabigatran, edoxaban and rivaroxaban in terms of choices of anticoagulants we can give to our patients.
Yeah, thanks so much, Javid. I mean, that's a great review of sort of what we have to sort of think about every time we see a patient. I know in the cancer population, that's a very tough conversation because there's already so many medications that you have to navigate. So this is certainly something that we're going to try to return to the cancer population with throughout this, because I think it's one of the most challenging aspects of VTE care. So shifting gears to that first learning objective, we're going to kind of define what we mean when we say real world data and how that fits into informing our clinical management of patients with VTE. We've got the randomized controlled trial data, and then we have the data that comes from our everyday clinical practice. And I think we need both. And what we've got is an amazing animated video to kind of explain what the difference is between these two bodies of evidence.
In medicine, real-world evidence, or RWE, refers to evidence derived from the use and analysis of real-world data, or RWD, which are data obtained outside the context of randomized controlled trials, or RCTs. While RCTs are the gold standard for assessing the efficacy of new therapies, the importance of RWE in medicine has been increasing, with the growing recognition that RCTs might not always accurately reflect the general medical patient population. In fact, in thrombosis studies, up to half of real-world patients are not represented by RCTs. It is unclear whether findings from RCTs can be generalized to these patients, and whether real-world patients respond to treatments in the same way as clinical trial participants. Here's where RWE can help. RWE may be more generalizable to patients in clinical practice and can aid in better understanding the impact of drugs while providing information on long-term follow-up and chronic use. Appropriate use of RWE can supplement traditional clinical research to aid in clinical decision-making, offer insights into treatment selection, and improve access to therapy for underserved patient populations.
Well, I think that video actually did a great job of showing the differences between controlled trial data and real world evidence. And I think that, as I mentioned before, probably both matter to our patients. The controlled trial data really helps to define what the indications are for. And then the real world data really helps us to see how our individual patient might fare with a certain therapy. As we look at real-world evidence and how it influences anticoagulation, we can look at the medical literature and just see an explosion in the number of real-world evidence studies that are published every week in the journals. I think what we've noticed is that as real-world evidence has shown our comforts with anticoagulation with the direct oral anticoagulants, we've seen that that's provided a lot of reassurance and actually expanded out the use. Javid, would you say that real-world evidence has helped you in incorporating the DOACs into your clinical practice?
Absolutely. When I look at the cancer patients especially, and I'm trying to decide what type of anticoagulants to use, you can never find one patient that fits exactly to the clinical trial described. Whereas when you extrapolate and use the real-world population, I feel most importantly safest about using newer drugs. And I've definitely seen this shift in my practice just over the last few years even. So I agree 100% on that.
Yeah, I would say probably, and let me know if you agree, Javid, that before we had randomized controlled trial data for DOACs and cancer, we relied heavily on real world evidence. It was observational studies. It was even sub-analyses of the trial data looking at smaller populations of cancer. But without those, we probably wouldn't have had enough to really map out and plan the big pivotal studies that are now sort of fueling the use.
Absolutely. I mean, part of it came down for me 5, 6, 7 years ago in terms of practicality. DOACs are easier to use, and in many patients, there was either the choice of not getting any anticoagulant or using DOACs. And frankly, if I had waited for data, the perfect randomized trial to come out, the patient would not have been getting any anticoagulation and probably wouldn't have made it. So it's these observational data and the real world data that have really helped us inform at least my clinical practice in the cardio-oncology population.
Yeah, definitely. Moving on to our second learning objective, we're going to really focus on the safety and efficacy of DOACs versus vitamin K antagonists based on the real world data. I mean, the trial data suggested that direct oral anticoagulants were certainly going to be as effective in venous thromboembolism, but safer. The lingering questions were, what happens when it gets out into the real world, into everyday populations of patients that maybe have varying kidney function, patients who have different body mass indices, then how do these things function? And I think that's where real world evidence really becomes so critical to what we're doing. And when we think about sort of anticoagulation and venous thromboembolism, there's different phases. At least it helps me to think of that. We've got the very acute phase where patients come in with their venous thromboembolism. We want high level antithrombotic efficacy. We want to prevent new blood clots from forming. We want to prevent embolization. We want to get those symptoms improved. Then we get into a sort of intermediate stage where patients are really may have some lingering symptoms, but they're largely improved, and we're trying to prevent recurrences. And then there's this whole idea of extended duration thromboprophylaxis, where in some cases it could be 6 months, a year. In other cases, it could be indefinitely, but we're looking to prevent recurrences in patients that have a little bit of a higher risk of that happening. I think that is where the whole idea of an oral agent becomes so attractive, right? Especially in your cancer population, they have a high risk of recurrence. And before the DOACs, we'd be thinking about what? Lifelong injectable therapy, which sounds miserable.
Yes. And I would say the same paradigms plays true with typical cancer patients that we see. Many times the patients initially are acutely sick, and they're in the hospital, they're being seen continuously by the doctor. But then many cases, we've been able to make cancer effectively a chronic disease. And in many cases, with respect to anticoagulation, I think those needs match the state of the patient too, as these patients become more chronic.
Yeah, I agree with that 100%. There's certainly been a very fortuitous evolution of our anticoagulation that's occurred at the same time that we've seen vast improvements in cancer care with patients surviving or living with cancer. Imagine what it would be like if we had to use injectable, if that's all we had. It would just be...
I mean, the truth is, with many of my patients, they would simply stop using anticoagulants. I mean, that's that simple. If you have to inject yourself every day, it's just not something that's practical for chronic stage, especially.
And some of you in the audience might be wondering, what about vitamin K antagonists in patients with cancer? Well, unfortunately, in that setting, it's never really been that effective. There's been a high rate of failure, and the studies that looked at low molecular weight heparins versus vitamin K antagonists always showed a better performance with the low molecular weight heparins. So really, without DOACs, we would be quite stuck with injectional therapy. Now, if we think about all of the trials, Javed, that look at direct oral anticoagulants versus vitamin K antagonists and look at some of the pivotal meta-analyses, what are the key messages that you've gleaned from these meta-analyses when it comes to efficacy and safety?
Yeah, I think the big picture, the big story that I take in for my practice is the fact that if you do meta-analyses comparing DOACs and vitamin K antagonists, you can clearly see that the DOACs have comparable efficacy and probably a better efficacy, although that's hard to tell, as you can imagine from meta-analyses. But I think the biggest and probably most striking thing that I take away from my practice is a significant lower risk of bleeding and that are associated with DOACs. And I think that's really an important point for just the what is important for the patient. And I think we see that very clearly across the board, whether it's major bleeding, clinically relevant non-major bleeding, and even fatal bleeding. And I think that's really important to sort of think about and take home with us as a message.
Yeah, no, I definitely agree with that. I think in the general population, bleeding's always first and foremost as what we want to avoid. We want therapeutic efficacy, but we don't want to have to pay on the back end with bleeding. I imagine that might even be more of a concern in cancer patients with all of the therapies and changes in platelets. Does bleeding end up being a big point of conversation for you and your patients?
Absolutely. Part of the thing to think about with what has happened to cancer therapies, we don't really cure cancer. We've made cancer a chronic disease. That means in many cases, patients remain on chronic therapies, and you basically change the therapies to go along. I'm talking about cancer therapies now. And many cancer drugs do affect platelets, and they can increase the risk of bleeding at any given moment with the titration of these drugs. So bleeding is an important consideration in all of our patients. Even though the patient is stable, the tweakings that are done by our oncology colleagues with respect to cancer therapies can suddenly really put the patient at risk of bleeding. And you put the anticoagulation on top of that, you may have a real problem. So I think it's really a big consideration for the practice.
So having something that's safer than low molecular weight heparins or warfarin becomes even more important.
Absolutely. I couldn't agree more with this.
So if we go on to our third learning objective, we're really focusing on how we weave in the real world evidence into our everyday practice, including how do we talk to patients about the difference between real world evidence and randomized controlled trials. I mean, explaining what an RCT is takes work in and of itself, and then you're going to talk about real world evidence. But I think it's important because these are the data that directly affect our patients. Many of our patients won't fit into the randomized controlled trial inclusion and exclusion criteria. We see real patients. I can tell you in the audience, Javed and I see real patients, complicated patients referred to our centers, referred to Javed's Cancer Center, and many of them would not fit into the trials that really substantiated the use of direct oral anticoagulants. So real world evidence becomes even more important. And we use that real world evidence to kind of understand the different avenues that we have for anticoagulation. So the first sort of real world evidence experience we had was sort of in the absence of major randomized controlled trials for bridging with parenteral anticoagulants to warfarin. I mean, there were some studies, but largely what we went on for the safe bridging of patients on low molecular weight heparin or heparin to warfarin was real world evidence, observational studies, and what our practice partners had taught us. As we got to the direct oral anticoagulant era, we learned that we had additional avenues for anticoagulation. There was switching, where some patients would get parenteral anticoagulants and then convert over to an oral agent such as dabigatran or edoxaban. And then we also had completely oral monotherapy, where patients would get something like rivaroxaban or apixaban at a higher dose initially for that acute phase, and then a maintenance dose for the sort of prevention phase. And while the randomized controlled trials informed us a little bit about what we could expect in making those transitions for patients, it's real world evidence that has shown us that this is really a safe approach. And it's real world evidence that suggests that we might be able to expedite patients out of the hospital and out of the emergency department with using DOACs preferentially. So it becomes very important to consider these real world evidence studies. Now, an area that I talked about, Javed, was this idea of extended duration thromboprophylaxis. So you certainly know this from your experience in cancer patients, because having cancer is one of these risk factors that makes the chronicity of VTE span outward for years, decades, and sometimes indefinitely. In the non-cancer population, we have other risk factors such as heart failure, chronic obstructive pulmonary disease, inflammatory disorders that also stretch out that time, that risk period well past 6 months. And so we have to consider some extended duration thromboprophylaxis, just like we do in the cancer patients. Unprovoked venous thromboembolism is another population where, even though we can't pinpoint the trigger for their venous thromboembolic event, they might have enduring factors that predispose them to recurrences, or since we can't tell them what to avoid, they're always going to be at some risk. Luckily, we've learned from some randomized controlled trials, but a lot of real world evidence that extending DOACs long term can help to prevent these recurrent events, and it can do it safely, which I think is a major step forward. I think it was really hard to talk to our patients about lifelong anticoagulation when the only options on the table were injections or vitamin K antagonists with warfarin. If you look at the guidelines, especially the 2016 CHEST guidelines, they really recommend preferentially looking to a DOAC. And I think it's because of what you said, Javed, because the safety is so impressive. You know, reducing major bleeding, reducing intracranial hemorrhage, that makes them great options over vitamin K antagonists. What are you seeing, Javed, in the cancer population? Are we going to see some guidelines really start to embrace DOACs? Would you right now consider them as an alternative or a preference?
In my practice, it's really a preference, to be honest. It's just the practicality of it. And we're already seeing this come into play with many of the guidelines that we think about. We're going to talk about the NCCN guidelines. I actually looked to a nice paper you and Mike Strife wrote last year, looking at the various guidelines, be it ASCO, be it International Society of Thrombosis, homeostasis, in terms of how these guidelines, how the practical things you and I are incorporating into our practice has really made it into the guidelines. This is an oncologist paper you guys co-authored, and it sort of really, I think, captures how we are seeing these, what you and I do in our daily practice incorporate into our clinical guidelines. So I think we're going to see more of that in the coming years with the different guidelines that exist for the better taking care of these patients.
Yeah, and you know, as we sort of talk about that progression from the general guidelines to the cancer guidelines, and we talked about randomized controlled trials in the general population and now the cancer population, are we starting to see meta-analyses putting together the wealth of information that we have for DOACs in cancer patients?
Absolutely. When you look at meta-analyses from the main trials like Caravaggio, SELECT-D, and others, you begin to see very much trends come into play. For example, with respect to DOACs, you have a decreased risk of recurrent VTE when compared to dalteparin. There is probably a slight increased risk for major bleeding and some increase in non-major bleeding. So this is actually a consideration one has to take into play. And then you can look at many, many different trials. Again, the trials are not perfect because it's really observational. And for example, if you look at a sub-study from Zalia, which is a multi-center prospective non-interventional observational study looking at rivaroxaban compared with standard therapy in patients with DVT, you can actually see that there is a significant decreased risk of VTE when you compare it things to other drugs and standard anticoagulation, you see significant less bleeding at the same time. I think studies like these inform us with respect to what we can apply to our daily practice. Another study, I like apixaban many times because of the less effect on the kidney function. And as you look at the cancer-associated thrombosis, and if you could look at U.S. claims databases, you can see that in large retrospective claims database, when you compare apixaban to low molecular weight heparin and warfarin, you see lower risk of VTE, lower risk of major bleeding, and even lower risk of non-significant bleeding, if you will. And I think this is really important to think about when you're comparing things to low molecular weight heparin or warfarin for that matter. So I think these these observational studies, although not perfect, they really help me in my daily practice take care of patients. Go ahead.
No, I was just going to ask, Javed, do you use these, like the claims data? It's such a huge population of patients. I would imagine like you could use that in your clinic to give patients some reassurance that they're not guinea pigs using these DOACs, that, you know, they're one of millions of patients that are getting this drug.
Absolutely. I think it's the sheer number of patients. When you look at the US claims database, how many patients are actually included? And just that number is far greater than any randomized clinical trial you could get. And I think the biggest concern that patients have brought up, or even physicians 5-6 years ago with newer anticoagulants, was safety, and safety specifically with the cancer patients. And I think the big takeaway for me is the less risk of bleeding and the safety of the drugs. That really reassures patients. I think that was the big, question mark I had 7-8 years ago in terms of the drugs that I would use for my patients.
Yeah, and it kind of seems like, as we segue to talking a little bit more about the NCCN guidelines, it seems that safety was first and foremost on their minds when they drafted these things.
Absolutely. We can again talk about many different guidelines: the American Society of Clinical Oncology, the International Society of Thrombosis and Homeostasis, literally every single group of vascular doctors and oncologists, the CHEST guidelines, have put out guidelines. And many times with guidelines, unfortunately, you have to wait some time for the perfect trial to come out so that you can see incorporation. I think the big take-home I take away from the NCCN is something you taught me years ago when we worked together closely, which was the recognition of risk in cancer patients. It's not so much the patients who are at risk of or who have had a VTE, but it's the surgical oncology patient that goes home. And just recognizing that even though they are home now, there's a risk of VTE that we have to appreciate, and how we have to incorporate prophylaxis in the population. And same goes with medical oncology patients. I think one of the big things I've learned over the last decade, or what we've been able to do in oncology, or what I see my colleagues in oncology do, cancer has become a chronic disease. Doesn't mean you get cured of your cancer, but rather you live with your cancer. And I think one of the key points is you live with your cancer because you are on chronic, often oral treatments with specific oncology therapies. So I think of the case of multiple myeloma. Now, multiple myeloma is the second most common cause of hematological malignancies in the US. It was essentially a death sentence 15 years ago. But with the advent of new therapies like so-called immunomodulators or IMiDs, we see those patients living much longer. Now, I think one of the big points that the oncologists learned early on is these multiple myeloma patients are living longer, but they're also on oral drugs. And it turns out these specific drugs, these so-called immunomodulators, IMiDs, drugs like thalidomide was the first drug, and then lenalidomide or Revlimid was the second drug that came in. These drugs by themselves, these very life-saving oncology drugs, substantially increase the risk of VTE. And I think one thing we have learned is this new space for taking care of the patients with respect to coagulation risk is prophylaxis, thromboprophylaxis. And I think of a great study that you and one of my colleagues at Vanderbilt, Frank Cornell, completed, where you look at safety of drugs like apixaban in this population. Again, these are not patients who have VTE per se, but they have cancer that portends a bad risk, and also drugs that significantly increase the risk of clots, basically. And you think about thromboprophylaxis in this population. And this is an area the NCCN has been particularly good about, specifically, for example, pointing out multiple myeloma, where with high-risk patients, you think about thromboprophylaxis and often using DOACs just because of the practicality with the drugs themselves. So I think it's really come into play with incorporating some of these in just practical guidelines that the oncologists use.
Yeah, I mean, I think you delved into a great area of how the DOACs even now are getting involved with prophylaxis. And certainly if we can prevent VTE and not have to treat it, it's even better. So in the last few minutes, I have a real world case that I want to run by you, Javed. It's the case of a 67-year-old woman with non-small cell lung cancer who had a left lower lobectomy in 2009 and is found to have some pulmonary nodules, which they're worried could be metastases on her surveillance CT scan. She's had some mild dyspnea on exertion. It was sort of gradual in onset. On her physical examination, it's really not that concerning. Normal heart rate, normal or slightly hypertensive blood pressure, but the oxygen saturation is decreased to 91% on room air. Lungs sound okay, no edema, but a worrisome picture in someone who's been treated for cancer. What's the first thing that pops into your mind, Javed, when you hear this story?
I mean, I think one of the things I learned 10 years ago was VTE thrombosis is the #1 preventable cause of death and morbidity, and certainly even morbidity in this population. So that's the first thing I think about. Again, a lot of other things to consider in this patient, given that the primary cancer is lung cancer. So there could be other examples for the hypoxia. But VTE and PE specifically is the main thing I don't want to miss in this patient.
Right. Yeah. And so it sounds like that was the same logic that the patient's clinician had, and a CT scan was done, which actually in the first cut demonstrated a little bit of SVC thrombosis around a port, which unfortunately I'm sure is not that uncommon, Javed.
Yeah, I think we tend to think about long-term treatments for patients, and many of times, at least initially in the type of diagnosis, these are IV infusions, and you have to have ports that basically allow you to have catheters to infuse the drugs. You're basically introducing a foreign object, and these patients are definitely at increased risk of thrombosis.
Well, I think that sort of also heralds the fact that as we look at lower cuts in the CT, we see evidence of pulmonary embolism. So your fears were well-founded and unfortunately confirmed on the CT scan. So the patient was ultimately diagnosed with a line-associated SVC thrombus and pulmonary embolism. And what would you propose for this patient for therapy? This was a surveillance scan. The patient's not hospitalized. They're at home. How would you manage this PE and SVC thrombus?
Yeah, I would say 15 years ago, I would have thought about low molecular weight heparin. But in this patient, again, given the fact that the patient is outpatient, I would certainly consider a DOAC for this patient. Again, I think one of the key points to think about is to recognize that the truth is the patient needs to kind of continue getting their cancer treatments. They probably need to have the line in place, and DOAC becomes much more practical for the patient. So I would say this is one area where my practice has changed in the last decade. Again, there's not a perfect clinical trial I could say and point and say, well, this is in these patients, all with catheter-associated PE, these patients are randomized. But taking away from the real-world patients, real-world data, I go with DOACs in this population or in this patient.
And I think that's what the patient's oncology team went with. The conversation went somewhere like the best place for this patient is home. And the best way to keep the patient home and to make things easier is with a DOAC. And the patient was started on a DOAC and did really well. So I think that the case nicely sort of describes what we got out of the real world evidence and data that we looked at. So if we're going to summarize, and I can't believe the time's gone by so quickly, but if we're going to summarize what we've talked about, we can go through our SMART goal action items. And the real conversation for us to take home is balancing randomized controlled trial study results with findings from real world data or real world evidence. That helps us to account for different patient populations and clinical scenarios that aren't included in the RCTs. We consider patient comorbidities, including cancer, especially when managing patients at risk for VTE. We try to incorporate oral DOACs when appropriate because they are great options for the immediate anticoagulation and certainly great options for long-term secondary prevention based on their safety. And of course, we've got to incorporate patient preferences and adherence issues if we're going to select an anticoagulation program that's going to persist, it's going to work over the long term. Javed, I want to thank you so much for being a perfect partner for this discussion, but also for your insights into the cancer population, which we know both is very, very quickly growing and a key population for VTE. We together hope that our audience found this information to be useful and practical as you go back to the clinics and the hospital to take care of patients. A few words for all of you. To access the whiteboard animation we showed earlier and additional CME Outfitter educational activities, resources, and tools to improve patient care, you can visit the cardiology and oncology hubs at CMEOutfitters.com. And you can see links. And then to receive your CME or continuing education credits, please click on the link to complete the online post-test and evaluation. Important to get credit for what you've done. Don't miss out on other important case-based programs in this VTE series. There's a lot of great content. You can access it through www.cmeoutfitters.com. And on behalf of Javed and me, thank you so much for your attention and be safe out there.